Friends, today we will discuss about ultrasound features of acute cholecystitis. That means how you will recognize acute cholecystitis on ultrasound. Acute cholecystitis means inflammation of gallbladder wall or inflammation of gallbladder. In 95% of cases, it is associated with gall stone, where it is called as a calculous cholecystitis. In remaining 5% of cases, that is in rare cases, it is associated with without gallstone, where it is called as a acalculous cholecystitis. There are certain clinical features in favor of acute cholecystitis. Those are pain in right upper quadrant of abdomen which is radiated to shoulder, fever, jaundice, tenderness and guarding in right upper quadrant of abdomen. These are the clinical features in favor of acute cholecystitis. Let's discuss what are the findings in favor of acute cholecystitis. First, leukocytosis, that means increased WBC count. Second, mass in right upper quadrant of abdomen which is occasionally palpable. Mass is formed by gallbladder and surrounding omentum. Third, Murphy sign or Nounin sign, that means inspiratory arrest with deep palpation. Fourth, Boas sign, that means hyporesthesia below right scapula. Fifth, mild elevation of serum bilirubin and liver enzymes. These are the findings of acute cholecystitis. Let's discuss sonic features of acute cholecystitis. You should know 4 findings in its favor. First, gallstone. 95% of cases, acute cholecystitis is associated with gallstone. So, you should search for gallstone where acute cholecystitis is present. Second, sonographic Murphy sign or sonomorphy sign. It should be present in acute cholecystitis. Third, thickened gallbladder wall. Thickness of gallbladder wall more than 3 mm in its favor. Fourth, pericholecystic fluid collection in its favor. 4 findings in favor of acute cholecystitis are gallstone, thickened gallbladder, sonographic Murphy sign and pericholecystic fluid. These are the 4 findings in its favor. Let's discuss what are the ultrasound findings in details. First, gallstone. As I have already discussed, 95% of acute cholecystitis is associated with gallstone. That's why when you are recognizing acute cholecystitis on ultrasound, you should search for gallstone inside it. But you have to recognize whether the stone is mobile or impacted. Mobile means it seeks gravitational dependence. That means on moving the patient to other side or changing the position of the patient, the stone should move to the gravitational part. Second, thickened gallbladder wall with sandwich appearance. Normal thickness of gallbladder wall is less than 3 mm. 3 to 4 mm is borderline and more than 4 mm is always abnormal. What do you mean by sandwich appearance of gallbladder wall? Normally, gallbladder wall has 3 layers which are not visible on ultrasound, but in acute cholecystitis, These three layers of gallbladder wall is easily detected. What are the three layers and how they look like we will discuss later. Third, pericholecystic fluid collection. You have to search for fluid collection or a hypoechoic area beyond its anterior and posterior wall. Fourth, sonomorphic sign or sonographic morphic sign. How sonographic morphic sign differs from morphic sign. In morphic sign, we are pressing the right upper quadrant of abdomen without localizing the gallbladder. That means we are pressing it blindly. But in sonographic morphic sign, after localizing it, we put pressure on it. Let's discuss procedure to perform sonographic morphic sign. Keep the gallbladder image at the center of the screen, which is correspond to center of the probe. Again I am telling, keep the gallbladder image at the center of the screen, which is correspond to center of the probe. At this point, you press the probe and patient will feel pain. That means after localizing the gallbladder on the image, you are putting the pressure. But in morphic sign, without localizing the gallbladder, you are pressing the right upper quadrant of abdomen. That means we are putting the pressure blindly. Lastly, you have to image CBD and take information whether it is dilated or not and what is its content. More than 6 millimeter diameter of CBD means dilated CBD. We will discuss about CBD in details in later. Normal gallbladder wall thickness never cross 3 mm. That means normal gallbladder wall thickness less than 3 mm. 3 to 4 mm is borderline and more than 4 mm is always abnormal. Increased gallbladder wall thickness that is more than 3 mm is not specific nor sensitive to cholecystitis. That means increased gallbladder wall thickness also seen in other conditions where it is called as a reactive increased thickness of gallbladder wall. The conditions are ascites, congestive heart failure, renal failure, hepatitis and AIDS infection. These are the conditions where reactive increased wall thickness without any inflammation. If gallbladder wall is thickened, always search for stone inside it. By taking the help of color box or color Doppler, you can able to differentiate whether the increased GB wall of thickness is due to inflammatory conditions that is cholecystitis or non-inflammatory conditions that is reactive increased GB wall of thickness. Again I am telling, color Doppler or color box can differentiate whether the increased GB wall of thickness is due to inflammatory condition or due to non-inflammatory condition. In inflammatory condition, there will be increased vascularity which is absent in non-inflammatory condition. This slide with longitudinal section of gallbladder with convex probe shows sandwich appearance of gallbladder, which means all three layers of gallbladder are easily visible. Outer layer is hyperechoic, which is due to serosal layer itself. Middle layer is hypoechoic, which is due to muscular layer itself. And innermost layer is hyperechoic, which is due to mucosal layer itself. Again I am telling, in inflammatory conditions all these three layers are easily visible, but normally in normal cases all these three layers are not seen. Sandwich appearance of gallbladder wall is in favor of acute cholecystitis. This slide transverse section of gallbladder with convex probe shows sandwich appearance of gallbladder wall, which is in favor of acute cholecystitis, where three layers of gallbladder wall easily detected. Outer layer is hyperechoic, middle layer is hypoechoic, and innermost layer is hyperechoic. Again, transverse section of gallbladder with convex probe shows three layers of gallbladder wall. That is sandwich appearance of gallbladder wall, which is in favor of acute cholecystitis. This slide with longitudinal section of gallbladder with linear probe shows sandwich appearance of gallbladder wall, where three layers are visible, which is in favor of acute cholecystitis, but normally three layers are not visible. This slide shows Gall stone with posterior acoustic shadow, sandwich appearance of gallbladder wall, where all three layers are easily seen. Fluid is collected, that is hypoechoic area, that is pericholecystic fluid collection beyond its anterior wall. All are sonic features of acute calculous cholecystitis. By taking the help of color box, you can able to differentiate whether the increased thickness is due to inflammatory condition or due to non-inflammatory condition. In inflammatory condition, there will be increased vascularity of the gallbladder wall, which is absent in non-inflammatory condition. This slide shows increased vascularity of the gallbladder wall, which is due to inflammatory condition. This slide of acute calculous cholecystitis, where gallstone with posterior acoustic shadow, pericholecystic fluid collection, sandwich appearance of gallbladder wall are present. This slide on color Doppler shows increased vascularity of gallbladder wall, which is in favor of inflammation. This slide with transverse section of gallbladder shows sandwich appearance of gallbladder wall, where three layers are seen. Let's see some slide with sandwich appearance of acute cholecystitis. Transverse section of gallbladder shows pericholecystic fluid collection with increased GB wall thickness. You should measure GB wall thickness from outer hypoechoic layer to inner hypoechoic layer as in figure. This is a slide of acute calculous cholecystitis, where gallstone with posterior acoustic shadow, increased wall thickness, and fluid collection, that is hypoechoic area beyond posterior wall, is visible. See the slide with sandwich appearance of gallbladder wall both in longitudinal and transverse section. If a slide shows sandwich appearance of gallbladder wall without any gallstone inside it, then before labeling it as a acalculous cholecystitis, always exclude it is not due to reactive increase in gallbladder wall thickness. Sandwich appearance of gallbladder wall in transverse section. Slide with sandwich appearance of gallbladder wall with fluid collection beyond posterior wall.